joining this seminar. We've been looking super much forward to this. This is the first in a range of series hosted under the Extracellular Matrix Pharmacology Conference, and we'll be continuing these. So I'm the chair of the Extracellular Matrix Pharmacology Conference, and today we're going to be talking of matrix in general, and then we're going to talk about in particular heart failure preserved ejection fraction. I'm starting as the chair because we had a wonderful time in Copenhagen last summer, and we will meet again in Copenhagen in 2024, where we will again be having an extracellular matrix pharmacology meeting. So in this series of events, the next one is actually tumor fibrosis. It will be Raghu Kalluri opening, giving the keynote talk. I look forward to that. There will be others coming. We welcome suggestions. We welcome different suggestions for speaks, and also for different sponsors that want to participate in this. Can I have the next slide, please? So I'm going to lead in the show, and I'm going to talk about extracellular remodeling. That is the common denominator in most chronic diseases. And I think in order to be truly efficacious and not just symptomatic, and even more, I think if we look into many of these chronic diseases, I think they may develop fibrosis because of two things. Either because of more tissue formation, or because of more tissue formation, or because of less tissue degradation. This picture is in fact taken in Denmark. It's on the northern part of Denmark, Skagen, where I sometimes reside with my family. In fact, it's a shifting dune, and sand move very slow, rather slow. But sometimes I think science moves fast. And I think what we're experiencing at the moment is that the field of extracellular remodeling is actually making a quantum leap. And we are getting a lot of information, and I'm going to talk about those. Can I have the next slide, please? So, of course, I'm going to talk about biomarkers. I'm going to talk about extracellular matrix remodeling in general, and I have brought with me some new examples from others in our own group on how we may remodulate this. So if we look into the us is like a crystal ball. We can find the patients that are fast progressing. We can find different endotypes, and I'm going to show you two endotypes, and I know the speaker afterwards is going to show you the endotype for heart failure preserved ejection fraction. And then we can use some of these biomarkers for drug development filters, that we can quantify them, and then we can see if some treatments may be suitable for development, or some should be stopped, or we can find a better treatment population. Next slide, please. So before we start, I have a few very to reflect on if we're going to move the field forward. First of all, the body regenerates. It's very simple. If we look into the bones regenerate every 10 years, and the epithelium of the intestine regenerates every week, whereas the liver can regenerate from just 25%. That means when we measure something, we absolutely need to know if that is a consequence of formation or degradation. If not, we do not know if a pharmacological treatment is going to inhibit that or lower that. This changed the bone field. There was two types of there was the anabolic, stimulating formation, and the anti-catabolics, inhibiting degradation. And so possibly we need to do some renaming in the fibrosis field, either pro-fibrolytics or anti-fibrogenesis, not just calling it an anti-fibrotic treatment, because there may be two different mode of actions we can do. Next slide, please. So one central part, I'm going to talk about collagens and how collagens and their fragments are affecting cells. It's actually 30% of all tissues. They are the backbone, just as the Eiffel Tower here, where you see that the type 1 collagen is the most abundant protein in the body, and there are 8 collagens on the top 10 list of the most abundant proteins. It actually is so that there are more collagens or more proteins, extracellular matrix in many tissues as compared to cells, especially if we are talking about fibrosis and in diseases where we have high tissue remodeling. Next slide, please. So this is just one simple slide showing that we really need to take into account how the matrix is remodeling cells. This is one of my first publications. It's osteoblast, and they were flat, cuboidal, and when we put them into a collagen gel, just type 1 collagen, suddenly they look very, very different. They become elongated osteocytes. And so this is when I got fascinated almost 25 years ago on the extracellular matrix. We've come a long way since then, and I think we are about to make that slow shifting dune becoming a very fast dune, because we are an entire community that are looking into these things. Next slide. So what are we actually going to use this for? Yeah. So what are we going to use this for? So of course, extracellular matrix remodeling is the common denominator of so many different tissues. And I'm going to talk in particular today on a metabolic sclerosis. I'm going to talk about liver, cardiovascular and kidney, and also systemic sclerosis. But the central common denominator in all these diseases is actually extracellular matrix. And we've been looking into this for the last 25 years. I want to emphasize a paper that came out in the New England Journal of Medicine with Arun Sanjay. And if I get the next slide, I think it's very important. It's just one highlight of this paper that, can I get the next slide, please? That if we look in this NASH population, to me that it's a metabolic sclerosis. There is a metabolic drive. And we know that these patients, if we look at the significant fibrosis, the F3 patients, they may have NASH, but diabetes issues, they have more kidney issues as compared to the NASH-related events. So this metabolic drive, changing the matrix of different organs, is super important. And when we change those organs, we are changing the matrix, but I think we're also changing the signaling. And that's why, of course, we're going to talk about signaling and matrix. Next slide. So I'm going to be highlighting a few areas of extracellular matrix research. I think that, though I know there was a new subclass of peptide hormones. And there's a range of publications coming out saying that fibroblasts are actually hormone-producing cells, and I'm going to emphasize a few of those. So I'm going to take two examples. I'm going to look at endostatin and the NC1 domain of the networking forming collagens, and asking the question, so what do they do? And then, of course, we're going to talk a little bit about endotrophin, this new collagen hormone that may be pro-fibrotic. But I think there are many things coming out right now telling us matrix, but in fact there are more things when we change the matrix. Next slide, please. So in a very simple highlight, then this publication coming out in 2022 is highlighting a few of those signals of the matrix. I think some of them are more robust than others. And I think some of them have been reproduced more than others. And I think it's because that cells are, of course, responding in their matrix and to those signals. I think we know well the type 18 collagen signal endostatin, and also the 15 signal restin. We know well the tumstatin and canstatin signals of type 4 collagen. And there are also a range of other signals in perlecan, tenascin, fibronectin, where we know that these fragments coming out of the matrix, they may have one meaning going in, and they may have another meaning going out of the matrix. Next slide, please. So this slide It's taken us 20 years to do. And so if we know the matrix, we know that under the epithelial cells, we have a basement membrane. And that basement membrane is consisting of network forming collagens. Those are very special collagens. They are permeable. They're beautiful collagens. Epithelial cells are smart cells. They know what way is up and down. They're highly specialized cells. So in the lungs, those epithelial cells, they allow oxygen to diffuse. And in the liver, it's blood. And so there's a diffusion. On the other side, we have the fibroblasts. They are stupid and aggressive and collagens. And they are very different. They're impermeable. And so because we're spending so much time on looking at the matrix, I mean, the take-home message number one is that collagens are not just collagens. We need to look at the right collagen, but also that the fragments are very different. So what happens when we look at extracellular matrix remodeling? Next slide, please. When we look at that extracellular matrix remodeling, what is that? If we have a damage to a healthy tissue, we actually induce damage, and that is resulting in activation of wound healing, clot activation. It will become important in a situation of inflammatory cells. Hopefully, we have tissue damage and repair. We've resolved the tissue, and we go back to normal. But sometimes the damage persists. We have damage deeper into the interstitial matrix layer, and that results in a difference in matrix remodeling. And this is what we quantify in the serum when we do biochemical markers. Next slide. So, a little bit about collagen evolution. It's a very nice paper for a Sunday. This paper by Fiedler et al. On the collagen evolution. So basically, and after the type 4 collagen, the basement membrane collagens, then we have the interstitial matrix. And we can understand that beautifully described in this paper, actually, that initially we had cells that did not need structure. But in the minute that you needed structure and bigger organs, there was need for bigger collagens. So if this is the phylogenetic tree of collagens, and interesting, you see that the type 6 collagen A3 chain starts out very different from being the odd filler here. And I think that's important for the rest of the talk and for the second talk, that there are some collagens that we know we are figuring out, and there are some that are very different. So I think they're good and they're bad collagens, and we need them at the right time, at the right place. Next slide. So what are these signals, collagen signals of the networking forming collagens? Well, there are actually three different families. So we started with the type 4 collagen, then there is the type 8 and type 10 collagen family, and then there's the type 15 and 18. Type 4 collagen family, those were the ones that were first. And then after that, we had the later collagens. And endostatin is a famous those signals do. Next slide, please. So if there was a very interesting paper by Yamaguchi et al. It's been a little bit hard for some possible to reproduce, but there was a range of papers coming out of Yamaguchi saying that in diseases with basement membrane fibrosis, with epithelial fibrosis, then this peptide from type 18 collagen, endostatin, that was actually antifibrotic. And we thought that to be very interesting. And so we saw that I'm losing slides. Can I get the next slide, please? So we saw when we looked into a simple either tube formation assay, a Boyden chamber, that endostatin was highly angiogenic. We know that endostatin, the fragment of type 18 collagen, is the most anti-angiogenic signal in the body. And there was other ones, restin, the fragment of another collagen that was equally anti-angiogenic. And if we look at tube formation assays, then there was a problem, because if you look in the literature, there's a range of experiments that work, and there's a lot of experiments that didn't work. Well, it took our group a long time to figure out what could be the problem. Next slide. And in fact, it turns out that there might be two signals. There might be a sticky sequence, and there might be a signaling sequence. And if we look into those sequences and we start to deconstruct that, we may actually get better drugs. Because some of the reasons that some of this failed was actually because of fibrillation of these peptides. So if we understand the peptides, if we understand the signals, we can actually modulate. And I think that's coming out of the matrix these days, and we're getting better at that. I need to talk about endotrophin, if I can get the next slide. So endotrophin is a new player on the block, originally identified by Philip Scherer. We were lucky enough that my team to quantify that. And I'm not going to steal the thunder from Alexander, going to be speaking in a second, but it is associated with chronic multimorbidity, of which heart failure is basically the most prominent effect. So what is endotrophin? Next slide, please. So we took this fragment of type 6 collagen, fibroblast cultures, and so we took that fragment and added to these cardiac fibroblasts or other fibroblasts, and we saw that adding not intact type 6 collagen, but a fragment, the propeptide endotrophin of the fragment of type 6 collagen, was actually profibrotic. What you see here is a dose-dependent increase of type 1 collagen formation in these cultures. So endotrophin and other hormones of the matrix that we are discovering have autocrine effects, possibly even paracrine effects, modulating the matrix. And if we change tissue turnover, I think we need to quantify formation, degradation, and the signals in that. So what is endotrophin? I think it's very interesting. I should say these data is actually originally done by Alexander, the second presenter in this next slide. So what is endotrophin? This is a schematic picture. So endotrophin is a fragment of type 6 collagen, but the A3 chain of type 6 collagen is very strange. It actually has 10 von Willebrand binding domains, making it, if not the most, one of the proteins with the most von Willebrand binding domains. It has the ability to bind platelets, dragging those platelets into the wound when we have wound healing. And of course, platelets are the biggest source of platelet-derived growth factor and TGF-beta. It means that there could be a perpetual driving loop of those collagens dragging in platelets and expanding wound healing. So endotrophin is a discovering story. We're beginning to understand part of it, and coming back to both the phylogenetic tree and what does collagens do. There's an association in wound healing. Part of it. We need more research to do that, and I'm sure the field is actually doing something here. Next slide. At least we are. Next slide, please. So I'm going to turn a little bit to biomarkers. So I'm fascinated by the proteomic era here. I think it's fascinating that we may have one gene and 1,000 different proteins. I could spend hours on this. I just want to say that when we quantify proteins, in order to take clinical chemistry to the next level, I think we need to say that there are total proteins. Fragments, there can be cryptic signaling inside, there can be polymerization, all collagens polymerize, and there can be even some post-translational modifications such as glycosylations. HbA1c is a famous example of that. So when we are doing protein discovery, when we find a protein that's important, that's step one. And then we need to find the right epitope. We need to find the proforms so we can measure formation and degradation. I'm going to show you a few examples of that. Next slide. Next slide, please. So initially, when measuring a protein, we quantify that in many different ways, and I'm showing you some brand new data on a quantified type 3 collagen. We just call that ProC3, but basically you should think of it as fibroblast activity and type 3 collagen information. In a second, I'm going to show you that degradation is another epitope, but the take-home message here is that quantification of one protein is not just quantification of that protein, but really a quantification of epitopes of that protein. Next slide, please. So what is type 3 collagen information? Well, when you have activated fibroblasts, that can be either TGF-beta, PDGF, it can be IL-6, other driving cytokines. The common denominator is activation of fibroblasts, leading to have these propeptides that are released into the circulation where we can quantify them as a surrogate measure of fibroblast activities and a fibrotic drive. That's basically what one of the biomarkers we quantify. Next slide, please. So how do we change that? We have an amazing collaboration with Quinton Anstey, and I want to show a few highlights of what we have been doing together. So this is a very low calorie diet. I mean, really low. 800 calories a day is less than I have for breakfast. So to me, it's a harsh intervention. But we wanted to see how fast does biomarkers quantified what we refer to as our usual suspects. We quantified type 3 collagen, type 4 collagen, if I can have the next slide, please, and type 5 collagen, type 6 collagen. So what you see is a group of NASH patients, later stage NASH patients, and ProC3 to the upper left, there is a degradation, or there is a continued decrease of ProC3 in these patients that have a very low calorie diet. And interestingly, at the follow-up period, they have begun eating again. Then it takes longer time to reactivate those activated fibroblasts as compared to deactivating them. It's 3 months after they started or ended the diet. In contrast, the other collagens, the repair collagen, the basal membrane, or the collagen that's essential for collagen formation, type 5 collagen, they go up directly after. But they can change fast. And interesting, endotrophin ProC6 did not change. If we want to take this one step further, next slide, please. We separated these type 3 collagen formation. I think this could be super important for the fibrosis field, because what we saw was that only the ones that were high changed. This is suggesting that there could actually be two endotypes. There could be a high formation endotype, giving us more formation fibrosis, but the ones that have low formation already, should they be treated with an anti-fibrogenesis treatment? They possibly should have a fibrolytic treatment, and that's why possibly you can have fibrosis because of two things, either more formation or less degradation. I think we need to separate those. Come back to in a second the common denominators of fibrosis and the differentiators of fibrosis. Next slide. So looking, I mean, to me, a good biomarker is something that has to do with outcome. And this is another fantastic collaboration we have with Alexander Krag from Odense. And together with Stine Johansen, and of course the liver team here, we looked at outcome. I'm going to show other diseases in a second, but we look at outcome. And if we look at the outcome of type 3 collagen formation, it was better that transient outcome. So fibrosis activity is important. But the most important thing here is actually the graph on the lower side. It means we can easily find the ones that will not have an outcome. If you do not have an elevated level of fibrogenesis activity, you may not have an outcome. So one, I think it's important that good biomarkers are associated with outcome. And in addition, when Stine did additional analysis, we saw that it's actually independent of the stage of liver fibrosis. So the stage and activity are two separate things, and the activity is actually at least as stage. Next slide, please. Okay, so again, I want to look at the other part of this. I want to look at the degradation. And so type 3 collagen can be degraded by many proteases, and we have found one that was degraded by MMP. So it's a cross-linked fragment. Next slide, please. And the way we are quantifying CTX3 or type 3 collagen degradation is by looking at a small fragment that is MMP degraded and cross-linked, so it's a sandwich acid. Next slide, please. So why is that different? So when we look at type 3 collagen formation, in these fibroblast cultures, if we add TGF-beta, we see much more type 3 collagen. But we did not see any CTX3. But if we digest the matrix then with MMPs, we can clearly see that there are tons of CTX3 being released. It means it's a true formation true degradation biomarker. So type 3 collagen formation comes out with activated fibroblasts, but this degradation epitope exclusively comes out when you have matrix that's being destroyed by MMPs. It's actually the first true fibrosis resolution biomarker, and it's matrix. Next slide. Okay, how does that look in a clinical study? So if this is a fantastic study in a collaboration with a pharma partner. We looked at ProC3, no new, and this is a double liver biopsy study. It's hepatitis C patients. We looked at ProC3, the progressors at higher level as compared to the regressors. But interestingly, it was completely the opposite with CTX3. When we look at that ratio, it was even too good to be true. So if you both have high formation and low degradation, ratio was much better in predicting outcome, in predicting delta fibrosis as one single biomarker. Next slide. Oops, I think we skipped one. So we've looked in outcome studies. I skipped those because I don't want to do a little bit of other indications. So I know of one true fibrosis resolution endotype, and Diana, together with Ida Lutzman, did this at Nordic. So they measured CTX3 in these bariatric surgery patients, and it actually goes up with 40% after bariatric. So it's really, if you induce a fibrosis resolution endotype, then CTX3 goes up. I can't wait to see which treatment is reversing endotypes or reversing fibrosis by shifting the balance between formation and degradation. Next slide, please. Okay, so I'm fascinated by common denominators and not common denominators of fibrosis. And of course, lungs is a particular example because we have a basement membrane, and the basement membrane I just referred to, that is networking forming collagens that are loose. We can get oxygen. That is overgrown by fibroblasts, and fibroblasts that are producing matrix, the impermeable fibrillar collagens, and we need to control that, of course. So together with Gisli Jenkins and Toby Maher and others, we've looked into the profile study. So that's 450 patients. Next slide, please. Where we looked into which biomarkers are prognostic for progression, and we saw that it's a common denominator. ProC3 was also prognostic for progression, and progression measured either by delta force vital capacity in this cohort. And so ProC3 was significantly elevated in all time points. But interestingly, type 1 collagen degradation, C1m, type 3 collagen degradation was equally prognostic. And those two biomarkers are not prognostic for liver fibrosis. They are not prognostic for many other types of fibrosis. So lung fibrosis actually has both a common denominator signal and a unique signal. There's more inflammation, there's more tissue degradation in this type of fibrosis as compared to others. I'm fascinated by this common denominators and specific or different types of fibrosis. Next slide. Then Yanni was doing fantastic research on endotypes, and I think this may be a little too smart for me. We're looking into different cluster analysis, and they found 3 different clusters. I'm not going to steal Yanni's thunder, but if you go to the next slide, then they could clearly see that these 3 different clusters had different survival times. So clearly cluster 2, that were more fibrotic as compared to the other ones, they had a ratio of death as compared to cluster 1 and 2. So we begin to find endotypes, not just in liver, but also in lung. And that endotype here, I think it's important. Are those treatments that are being developed, are they more efficacious on either 1, 2, or 3? I think it's a start of segregating IPF patients even better. Next slide, please. So I just want to emphasize that in order to understand matrix, I think we need to quantify it also in preclinical settings, and from cell cultures actually to ex vivo cultures of human lung into a clinical study. We quantified some of the same biomarkers. I think it's important if we're going to change drug development. I think we need to have true translational science looking at the same biomarker throughout. It's a side remark. I just want to emphasize that it's important to quantify these in cell cultures so we can understand what they're doing. Next slide, please. One hot topic these days is tumor fibrosis. It turns out that cancer is truly a fibrotic disease, and I can't wait to see Raghu Kalua's talk. So around the cancer cells, we have tons of collagens. We actually have more fibroblasts than tumor cells in some of these solid tumors, in particular in panc. And so Nicholas here looked at 8 different studies and 5 different cancer types and saw that type 3 collagen formation was actually prognostic for outcome in all of them. So clearly, collagen formation, tumor fibrosis activity was important. Before I show what that can be used for, I just want to show you that the epitope is really important. Next slide. When we look at, can I get the next slide, please? When we look at different collagens, so to the left you have the fibrillar collagen, and to the right we have basal membrane, to the right we have networking forming collagens and facet collagen. So type 1 collagen formation was not different. We didn't have any diagnostic effect of type 1 collagen formation. And that's a standard biomarker on the Roche platform. And I think that may be why the collagen research have received too little attention, because when standard biomarkers are measured, there are no differences. However, then it was highly prognostic. But the fibrillar collagens, they are some of the most abundant collagens in the body. So the signal to noise ratio becomes much better if we look at some of the less abundant collagens, and the area under the curve for separating for separating healthy from cancer patients, that was close to 1 with a few of these biomarkers when we're quantifying the basal membrane collagens and the facet collagens. I'm sure that Nicholas will talk much more about that. But what does that mean for patients? Next slide, please. What does that mean? 3 just at baseline, and then this is from different studies with metastatic melanoma. It's different immuno-oncology treatments, either CTLA-4 or PD-L1s. Clearly, the ones with high fibrotic activity had a much worse outcome as compared to those with lower fibrosis activity. So the good news is we can identify the patients that will benefit from IO. The bad news is we need to do something else with those other patients. Next slide, please. So I want to emphasize that these tissue turnover profiles, I mean, they can also be used for autoimmunity disorders, and I hope we'll have symposium focusing on tissue destruction or autoimmunity. This is a fantastic collaboration we have with Ola Ditzler, came out in Lancet Rheumatology. And I just want to emphasize that there are common denominators and not common denominators. So start with ProC3. If we look at the light blue ones, those are healthy controls. Then we have stable patients and progressive systemic sclerosis patients. And ProC3 is higher in the progressors as compared to healthy. Again, it's a hormone that is fibrogenic, and it's higher in progressors as compared to stable, and also compared to healthy controls, of course. But now if we look at type 3 collagen degradation, C3M, then the degradation is elevated in those that are healthy, in those that are stable. So it means that you need resolution of the matrix. You actually need degradation. It's a good thing in these patients, because if you do not have that degradation, then you are progressive. We looked at the balance, and there was an area under the curve of almost 0.9. It's Anne-Christine Bay-Jensen was. And importantly, if we look at basement membrane C4M, so you needed a repair process. If you had a high level, you're actually stable as compared to the progressors that had a lower level. So I think that's important for understanding matrix turnover in different disorders. There are common denominators, and then there are the unique fingerprints of tissue turnover in these different diseases. Next slide. So Alexander is going to talk to us about another endotype, and I just initially that we can find different endotypes, that there are high turnover, low turnover. We need to look at formation and degradation. And if we're looking at these different disorders in lung, liver, skin, kidney, and heart, that are changing the matrix. I think we need to change the matrix back. And I think we need to understand how are those signals in the tissue actually change. And we can quantify them now. We can quantify endotrophin, endostatin, these fragments, these signaling fragments coming out of the matrix. And some of them, if we do this correctly, may even be drugs for some important diseases. So thank you for your attention here. And I can't wait to see what Alexander will be saying. I want to emphasize, I think we will have questions and discussions in the end after this. Alexander.
All right. Thank you so much, Morten. I just want to say that in the meanwhile, we know that there are a couple of issues with the slides and this video disappearing. We are working on that, and we will be back in 2 minutes where we will resume the slides. Thank you.
All right, I hope everyone can see me on screen and see my slides. So before I get going, I just want to take this opportunity to first of all thank the ECM Pharmacology Congress, but also Nordic Bioscience, for providing me with the opportunity to present this story, these data to you today. And also, of course, to all the participants that are online. And thank you very much for taking your time out of your schedule to attend here today. So my title or my presentation will cover, I think, 4 key areas. The first one is a bit of an intro on how we can use what we know about ECM biomarkers in chronic pathologies, especially those that are prognostic for outcome, and ultimately how we can learn from what we know and how we can implement that knowledge to guide drug development. As Morten also mentioned, I will spend some time on the endotrophin molecule, which can be measured by our Pro-C6 biomarker, with HFpEF as a special case. Last but not least, I'll end with some discussions and perspectives on how we can use tissue turnover profile for patient selection in clinical trials with the possibility of dramatically improving trial success and outcome. So my name is Alexander Petersen, and I did an industrial PhD at Nordic Bioscience. I worked predominantly on assessing circulating biomarkers of extracellular matrix remodeling in cardiovascular diseases, primarily focusing on heart failure. In addition to that, I also studied the potential profibrotic effects of endotrophin in vitro. And what I found was that actually the molecule itself is directly profibrotic when stimulating or treating human cardiac fibroblasts. In addition to that, during my time as a PhD was also the first time we saw a clinical validation of the biomarker in the TopCat cohort through a collaboration with UPenn and BMS. I then continued as a research scientist, and during that period as a research scientist, I saw the transition of the Pro-C6 biomarker assay to the Roche Cobas platform, which is an immensely important transition because it, first of all, increases the technical aspects of measuring the biomarker, but it also opens up for IVD-based decision making down the line. In addition to that, the transfer to an automated platform will also make the biomarker assay worldwide available, which is great for both clinicians and patients. In this period, we also applied for and received a letter of support from the FDA. Specifically, we applied based on the grounds that we saw good data, prognostic data in the TopCat cohort, and we got awarded this letter of support for the use and future studies of PRO-C6 as a trial enrichment biomarker in HFpEF trials. The past year or so, I've received another hat at Nordic Bioscience, so now I also work as an alliance manager, and this basically means that I bridge the gap between Nordic Bioscience and all of our pharmaceutical alliances and collaborations in the cardiovascular space. And this has, of course, allowed for an even deeper dive into the clinical aspects of implementing this biomarker in particularly HFpEF trials. And it just so happened that, as Morten mentioned, that last year in September, we were fortunate enough to get a story highlighting the clinical association between endotrophin levels and risk of outcome in HFpEF accepted for publication in New England Journal of Medicine Evidence. So before we get down into the actual data and biological context, I just want to start off by setting the stage, saying that I believe if we are to truly utilize what we know about the extracellular matrix for improving drug design, development, clinical trial design as well, and most importantly, also patient benefit, I think there are three key factors to understanding how we go about this. The first one is understanding the common denominator, which for our case is ECM formation and degradation. But as Morten also mentioned, there's an increasingly important aspect of this as well, which is ECM signaling. During this pathological turnover, more and more collagens that we know of right now, at least anyway, are releasing these matrix cryptins that directly can contribute to pathogenesis. It's also important to understand that there are tissue or pathology-specific ECM turnover profiles, that these specific organs or different organs with different diseases all display different protein fingerprints, depending on the specific pathology. In this context, it's also important to think about fibroblast activity. And taking together these two things combined into a biological context is important to understand how diseases might develop. Last but not least, there is also a design and development aspect to this. We need to know which pathways to target. And if we can provide novel pathways based on ECM turnover, I think that's very beneficial for drug developers. We can also evaluate, or should aim at evaluating, target engagement and effects on the specific diseases. And last but not least, to evaluate mode of action using our specific biomarkers. So before we get down into the actual clinical data, there's one more thing I want to discuss, and Morten also hinted this in his presentation, which is that regardless of what fibrotic etiology or disease we're looking at, there is a common denominator, and we've been increasingly aware that over the last period of time, that's the very, very common thing that binds all of this together is to some extent metabolic dysregulation. And we know, for instance, in obese patients that they have increased levels of angiotensin II, also increased levels of free fatty acids, meaning that the renin-angiotensin system activation is increased. There are more reactive oxygen species in the vasculature. There is decreased glucose uptake and insulin secretion, with a subsequent increased lipogenesis and gluconeogenesis, as well as circulating triglycerides. In addition to this, we also have more pro-inflammatory factors like IL-6, TNF-alpha. And last but not least, there are factors released from adipose tissue, in particularly leptin, but also endotrophin. And that's particularly interesting because we've seen time and time again that endotrophin is actually associated to this sort of metabolic sclerotic phenotype, as we like to refer to it. So I think there are four key components that comprises the metabolic syndrome, and it's regulation or hormonal activation, it's inflammation and insulin resistance, and also hypertension. And common for these four factors is that they usually manifest in type 2 diabetes or cardiovascular disease, particularly cardiovascular complications. So put into context of fibrosis, this is actually outlined quite nicely in a review by Chao et al., showing that the major organs of the body, liver, kidney, heart, and lung, are all susceptible for this metabolic dysregulation, which subsequently alters fibroblast metabolism, leading to an increased fibrotic response, disregarding what organ you're looking at. So I think it's important to acknowledge that HFpEF patients or chronic kidney disease patients or NAFLD patients do not only suffer from a specific fibrotic response in that respective organ that is the highlight of the disease, they're actually very likely to have a chronic fibrotic sclerotic systemic phenotype in which we see fibroblast activity being increased in all organs. And I think that's an important point to acknowledge in the context of fibrosis. Morten went over the extracellular matrix. I'll touch upon it briefly, just by saying there are 28 different types of collagen. They all have different structure, form, and function depending on where in the matrix they are. Now, in the middle of it all, in this figure, you'll see that type 6 collagen is residing. And what's so interesting about this collagen is that it actually spans the two zones of the extracellular matrix, so going from the basement membrane to the interstitial matrix. Upon the release or synthesis of new type 6 collagen, there is also the signaling molecule endotrophin that is released. And this is a very interesting biomarker, and I'll get back to why in a couple of slides. Before we get into that, I just want to touch upon how Nordic goes about developing or quantifying extracellular matrix turnover. So we know that unique protein epitopes provide unique information, but it's really important to understand the biological context of this information. So Nordic Bioscience designs biomarker programs based on two processes. One is fibrolysis, so degradation of extracellular matrix, and one is fibrogenesis, meaning formation or increased formation of ECM proteins. Common for both processes are that specific new epitope fragments are released into circulation. And these epitope fragments can then be targeted by, in our case, monoclonal antibodies that recognizes these fragments with high specificity. Subsequent to that, proteins have different domains. They have different structure, as I mentioned. So selection of the right epitope is crucial to the biological data output, so to say. This is just two examples highlighting type 1 and type 18 collagen. And as you can see in type 1 collagen, it has a long triple helical domain that is crucial for assembling the long fibrillar fibers, characteristic of type 1 collagen. But during its processing, propeptides are released in formation, and this collagen can then be modified by enzymatic processing too, leading to degradation epitopes as well. On the other hand, you have type 18 collagen, which is a vastly different collagen, speaking about the structure. But interestingly enough, you'll also see that there is a cryptic signal in this collagen, in this case called endostatin, which is probably one of the best known signaling domains of collagens. So it's really important to know that, first of all, you're targeting a structural different protein, but also that this structural different protein might have additional information, in this case in relation to bioactive signaling. So the key message is not to measure or focus on proteins, but actually look at epitopes. This figure highlights the many biomarker programs that are developed right now that all quantify formation and degradation of type 1 collagen. I'd just like to highlight one example, which is two forms of degradation of mature type 1 collagen, which is C1m, which measures soft tissue degradation. And then you have CTX1, which measures bone resorption. So just by looking at type 1 collagen in general, just depending on the specific epitope you're actually looking at, you'll get two very, very different biological inputs or information about two very different biological processes. So CTX1 has always been an interesting biomarker at Nordic Bioscience because it sets the stage for the beginning of our precision medicine journey, so to say. In this case, on the graph to the left, it says serum cross-labs. That's the new name for CTX1. And on the right, you'll have the conventional method for assessing bone structure, which is bone mineral density, which is an imaging-based method. What's interesting about this is that it measures the same patients and the same duration of therapy. And what you'll see if you look at the graph to the right, at 6 months of treatment, the difference between placebo and those patients receiving the highest dose is actually around 5%. If you then look on the graph to the left at the CTX1 measurements, you'll see that after 6 months, the difference is 75% comparing placebo to the highest group. That's 75% different within 6 months, 70% on top of what is done by the conventional method. So this means two things. First of all, ECM biomarkers can be more efficacious, and they are often more dynamic than the imaging-based or conventional methods for evaluating patients. The second part of this that I find truly interesting is that you'll see that the response to treatment is actually quite stable in those patients receiving the highest dose if you measure it by CTX1. So potentially, you could shorten down trial duration to as little as 3, 6, or 9 months and still have a very efficacious evaluation of your treatment. And I think this is an interesting example because it's applicable to a lot of the different biomarkers that are working in different indications out here in Nordic Bioscience. So soft tissue extracellular matrix dynamic turnover is also very dynamic. This is 2 examples, one from patients suffering from myocardial fibrosis. The other subset is suffering from type 2 diabetes. And if you look on the graph to the left in patients with myocardial fibrosis, you'll see that they have quite elevated degradation of type 3 and type 4 collagen compared to healthy controls. They also have elevated levels of collagen formation. But what's interesting is if you pair the net turnover of collagen, so in this case, Pro-C6 and C6M, that's formation and degradation of type 6 collagen, you'll actually see that the patients have significantly decreased levels of degradation, but significantly increased levels of formation. And this means that the net deposition or the net tissue turnover of type 6 collagen in these patients favor a fibrotic phenotype. If you look on the diabetes data on the right side, you'll see that they also have significantly increased formation, but very increased levels of tissue degradation as well. If you look at C1M, that's measured in both the diabetics and in the myocardial fibrosis patients, you can see that they have a roughly 5-fold increase in the diabetes patients, but a non-significant increase in the myocardial fibrosis patients. And I think that's truly interesting in the context of speaking about metabolic endotypes, because diabetes is known to be involved or have an inflammatory component as well, and is greatly affected by this metabolic syndrome endotype that we're talking about. So it's interesting to see that it actually appears that degradation of ECM is prevalent or prevailing in type 2 diabetics, whereas in myocardial fibrosis, it's a bit of a different picture. Right. So endotrophin, as I mentioned, is a particularly interesting biomarker in the context of a metabolic fibrotic endotype, but also a very good biomarker in relation to metabolic dysregulation. So if we start up at the left top corner on this figure, you'll see that I put in different stimuli that activates fibroblast. It could be the classical profibrotic signaling, including TGF-beta. It could also be tissue injury or damage, and this metabolic insult that I started out by talking about. Common for all of them is that regardless of how fibroblasts are activated, they become activated and differentiate into myofibroblasts. This leads to increased levels of collagen formation, in this case type 6 collagen. And what you'll see is that when type 6 collagen is secreted to the extracellular matrix, it's processed in the C-terminal fragments, meaning that they're cleaved off. We now know that from the type 6 collagen alpha-3 chain, the C5 domain is immediately cleaved off, and then there is a subsequent cleavage by a protease called BMP1 that leads to the release of the bioactive hormone called endotrophin. Endotrophin has a range of deleterious effects. Just to highlight 3 of them, it stimulates epithelial mesenchymal transition. There's also, as I mentioned at the very beginning, a direct evidence for a profibrotic effect in human fibroblasts, meaning that it also stimulates ECM formation or fibrosis. It also acts as a chemoattractant on macrophages and as a general stimulant. So besides all of this, endotrophin is also released into circulation, and this is where we can target the molecule as a biomarker, measuring both fibrosis in terms of type 6 collagen formation, but also endotrophin abundance. So endotrophin is involved in chronic conditions, and this is work done by a colleague of mine called Bine Stavnstrup. And she worked on a cohort we have actually run ourselves called the PERF study. It includes postmenopausal women that are followed up for decades here in Denmark. And what's interesting about it is if we look at the association between endotrophin levels and various types of disease, you can see that at baseline, there is a clear association between cardiovascular diseases. But the most prevalent disease type being associated with endotrophin at baseline is by far chronic liver disease and chronic kidney disease and diabetes as well. So again, if we go back and think about this metabolic dysregulation context, it actually makes sense, because you would expect the patients to first present with metabolic dysregulation, which, and first in line of that is of course chronic kidney disease and chronic liver disease, diabetes. But if we then look at the follow-up time point, you can see that many of the cardiovascular diseases actually become highly associated with endotrophin levels at follow-up, whereas we see a decrease in the association between both chronic kidney and chronic liver disease and diabetes as well. So my take on this is that you have some sort of metabolic dysregulation clearly that maybe predisposes you for developing cardiovascular risk over time. But what's interesting is that it appears that endotrophin is the common denominator between the metabolic phenotype or risk phenotype and your risk of developing cardiovascular diseases down the line. And that's a very important point that I'll get back to when we start talking about actual data. Line also showed that ProC6 levels or endotrophin levels increase with the number of morbidities these patients suffer from. So you can see that as you increase from 1 to 3 to 4 up to 7 different types of diseases at baseline, there is a clear association with increasing levels of endotrophin. And this only becomes more prominent when we look at the follow-up time point. So the conclusion based on these analyses is that endotrophin appears to be associated with some sort of metabolic predisposition or changes, but also that it actually increases with the number of comorbidities. Again, to my knowledge at least, or what I take away from it is that endotrophin is not specific for one type of disease. It's a biomarker reflecting systemic changes or systemic risk, and we need to dive deeper into that to further or to truly understand it. So one of the major questions that we get is that since you measure the biomarker in circulation, is it then associated to specific pathologies? And the short answer is no, because it's a systemic biomarker, and as I just mentioned, it does not appear to be specifically associated to one type of disease, but always to be associated with a high risk of developing cardiovascular complications. So these tissue sections shows different stainings from fibrotic tissue. You can see in the non-fibrotic kidney, the total staining of type 6 collagen is definitely present, albeit low. When you then stain for collagen type 6 in fibrotic kidneys, there is a remarkable upregulation of expression. But interestingly, when you only look at the ProC6 molecule or endotrophin, there is no staining whatsoever in non-fibrotic kidneys, but the fibrotic kidneys definitely stain for endotrophin. The same thing is basically seen in HFpEF tissues, and that's probably one of the most interesting findings I've seen the last year, because it demonstrates that not only is endotrophin a circulating risk biomarker for in HFpEF, it's actually directly associated to tissue changes on a local level in patients suffering from increased fibrosis in the heart. So if we look at another organ that's known to be affected by metabolic changes, it's chronic kidney disease, or the kidney in particular. And we know that endotrophin is a good diagnostic biomarker in kidney disease. Regardless of how we put it and what indication in kidney we analyze, endotrophin always comes out as highly associated to increased disease severity, in this form portrayed by an increase in CKD stage. And that's disregarding whether you have high-risk CKD or mixed CKD. Also in the case of diabetic nephropathy patients, both in type 1 diabetics and type 2 diabetics, we see the same thing. Endotrophin levels increase with an increase in disease severity. This is also applicable in end-stage renal disease patients and renal transplant patients. And last but not least, also in IgA nephropathy and ANCA-associated vasculitis. So taken together across kidney indications, regardless of what subtype you suffer from, you always have a strong association between endotrophin levels and disease severity. So that of course raises the question, is it also a prognostic biomarker? And in CKD at least we know it is. It's highly prognostic for development of end-stage renal disease, but also all-cause mortality. And what you can see if you look at the graph to the left, that when you increase in quartiles, so you increase in fibroblast activity and endotrophin abundance, you actually very dramatically increase your hazard ratio, so risk of developing end-stage renal disease. The same thing is applicable for mortality. And if we just look at the hazard ratios, there's a 7.2-fold increased risk of developing end-stage renal disease if you have high levels of endotrophin, and a 12-fold increased risk of developing all-cause mortality within 5 or 6 years. And that's all just on baseline levels of endotrophin. In diabetes, we see more or less the same picture, but in diabetes, it's more disease progression and risk of developing cardiovascular complications. In this case, heart failure, cardiovascular death, a composite of the two, or all-cause mortality, and we basically see the same thing. High baseline levels of endotrophin leads to a significantly increased risk profile when you look at these outcomes. And again, the hazard ratios hover around 1.5, 1.6 for developing these cardiovascular complications in diabetes. So again, it's another association between a pathology that's definitely impacted by a metabolic component and risk of outcome. So going to heart failure, this is where I've spent most of my time. And as I mentioned back in September last year, I was fortunate enough to co-lead the publication on endotrophin in the New England Journal of Medicine Evidence with Drs. Julio Torinos from UPenn and Lei Chao from BMS. And the first part of our paper explores the discovery cohort, which is the TopCat cohort. And what's interesting is that the first analysis, which goes to investigate the association between endotrophin, the MAGIC composite risk score, and NT-proBNP, and their association to the primary endpoint of the trial, which consisted of cardiovascular mortality, aborted cardiac arrest, or hospitalization for heart failure. What we did in this analysis was to adjust endotrophin for both MAGIC and NT-proBNP, and adjust MAGIC and NT-proBNP for endotrophin. And what we found by doing that is that endotrophin remains significantly predictive of the primary endpoint, even when you adjust for MAGIC, which incorporates a vast array of clinical parameters, and NT-proBNP, which is actually the golden standard for both diagnosis and prognosis in HFpEF today. Conversely, when we adjust MAGIC and NT-proBNP for endotrophin, they actually lose their significant association to the primary endpoint. And what's further interesting is that the confidence intervals in this analysis do not overlap in any way. So what we concluded, or at least hypothesized, is that this must mean that endotrophin adds some sort of biological information that is not reflected in any way by either MAGIC or NT-proBNP, potentially indicating that there is incremental value in including this biomarker in heart failure trials. Much like we've seen for both kidney diseases and diabetes, when you stratify patients at baseline according to levels of endotrophin, there is a very, very clear patient segregation according to risk. And as you can see here as well, in relation to the primary endpoint, patients with high levels of endotrophin and fibroblast activity are significantly higher exposed to the risk of reaching the primary endpoint. The centerpiece of this publication was a meta-stage analysis or validation of the TopCat findings in 6 independent HFpEF cohorts from around the world. So, as I mentioned, these are cohorts that are found both in the US, in Europe, in the eastern parts of the world. And what's interesting about them is that they represent very different demographics and geographic patients. What we found is that disregarding all of this, there seems to be, or there was a approximate hazard ratio of 2 when we look at the association between endotrophin levels and all-cause mortality in this case. Again, indicating that it doesn't really seem to be that important where you're from. If you have high levels of endotrophin, you have significantly elevated levels of experiencing a heart endpoint. Very important to also mention is that we didn't only analyze Proteus-6 in the TopCat cohort, we actually analyzed both formation and degradation of type 3, 4, and 6 collagens. And what's so interesting about this figure is that, as I mentioned, Proteus-6 is by far the best biomarker that we analyzed. Proteus-3 is also significantly associated with all-cause mortality in this case. But what's interesting is that if we had looked at another epitope, for instance, one of degradation, we would not have seen anything. There wouldn't have been a positive association in this analysis. So on one hand, we analyzed Proteus-6 that led to possibly the most important finding of a novel biomarker in HFpEF in many years. Had we only analyzed or looked at type 6 collagen as a whole protein or analyzed degradation, we would not have made that discovery. And I think that's that important, and it really underlines the importance of understanding the biological context when you're analyzing these different epitopes and biomarkers. So I don't think I could say all of these things without also touching on the most relevant question: why even develop a new biomarker for HFpEF? I know there are a lot of people signed up for this symposium that work in HFpEF, and they will also ask this question. And actually, last year, back in 2020, James Denucci, who is a KOL in the heart failure field, he published this editorial, and he stated that NT-proBNP is a less than perfect biomarker in HFpEF. It's considerably influenced by clinical factors that are known to drive or influence HFpEF, such as obesity, atrial fibrillation, and renal function. Again, two of those, obesity and renal functions, are both parameters highly associated to metabolic dysregulation. And even more so, NT-proBNP levels can actually extend down into the normal or healthy range for these patients, meaning that you can have a HFpEF patient that is severely ill, but who actually presents with levels of NT-proBNP that are below the diagnostic criterion for diagnosing HFpEF. So that begs the question, how do we then assess the risk in these patients accurately? James Denucci then concludes that it's likely that a simple biomarker strategy will not suffice. And I've brought this example today because I think it applies to more fields than just HFpEF. Many fields have established biomarkers. Many fields also have novel biomarkers being discovered. But I don't think we should see it as a competition, but rather it should be an aim for complementation. So we should develop new biomarkers in HFpEF to improve risk stratification and patient characterization, because the PRO-C6 biomarker assay, as I mentioned, measures both fibrosis and endotrophin abundance, which are two unique biological informations that you do not get in any other types of biomarkers today. There is a strong prognostic association to outcome irrespective of comorbidities. It's also available on an automated platform, soon to be worldwide available as well in the Roche Cobas platform. And we actually have a stamp of approval from the FDA saying this is a good idea. This is an interesting biomarker and one you should investigate further as a clinical trial enrichment tool in HFpEF. So we should develop new biomarkers in HFpEF and every other indication, basically, to improve risk stratification and patient characterization by improving upon the tools we already have available. So that leads to my conclusions and perspectives for this presentation. The first one, of course, and I hope many are wondering anyway, is whether or not modulating endotrophin is an interesting target, and I definitely believe that it is. So we've seen in diabetic kidney disease from the AWARD 7 trial, where patients are treated with dulaglutide, that there actually is a significant reduction in circulating endotrophin levels with treatment. We've seen the same thing in IgA nephropathy with Nefecon treatment. There's also even a dose-dependent decrease in PRO-C6 levels. And probably most interesting in relation to sort of the direction the obesity, diabetes, and HFpEF field is headed, is that when we treat an in-house ZDF, so that's a diabetic, obese, and potentially also renal injury rat model, when we treat this model with semaglutide, we actually not only stabilize levels of PRO-C6 compared to the vehicle, we actually inhibit it. So this is the first time I've seen clear preclinical evidence that direct metabolic regulation actually leads to lower levels of PRO-C6. And I'm, for one, am very excited to see whether or not this will translate into clinical trials as well, for especially semaglutide, but also tirzepatide, to really understand whether or not these metabolic compounds will regulate the levels of PRO-C6 in clinical trials as well. Last but not least, I think we can do better. I think we can take patient segregation one step further. So Morten and I had a long talk about how we can sort of build upon the New England Journal of Medicine publication. And what we did was to use our knowledge about PRO-C6 and divide patients into what we know are healthy levels below 8 nanograms per ml, or high levels and high risk segment of patients, which is above 15 nanogram per ml. What we saw upon doing this from one of the cohorts in the New England Journal of Medicine publication, we see that we roughly get a hazard ratio of 10 when we look at risk of heart failure hospitalization and all-cause mortality. Furthermore, I think it's very interesting that if you look at the graph to the left for heart failure hospitalization, there's actually a roughly 25% increased risk within 1 year after diagnosis that you are rehospitalized for heart failure, which is an immense problem in HFpEF. Also looking at all-cause mortality, if we look at a 3 to 5 year risk, the patients that have low levels of PRO-C6 only have a 2 to 10% risk of experiencing or reaching mortality, whereas patients in the high-risk group or high PRO-C6 levels have a 30 to 40% increased risk. So I think this is, at least for my own case, the strongest baseline stratification I've seen of patients in HFpEF currently with any biomarker in the field. And that, of course, leads to my final slide, that I think we should use endotrophin to identify patients that have an optimal chance of responding favorable to treatment, meaning that if you don't stratify patients at all, we don't believe there is likely to see a big treatment response. Whereas if you stratify using PRO-C6, you might only get 50% of the patients, but there's definitely a great expectation for seeing a positive treatment response. So my very last slide is just to highlight Nordic's vision and statement, and that is to address the gap between biomarker discovery, clinical utility, and commercialization. So we spend a lot of time going from refining our clinical assays, putting them on automated platform, and ultimately also transferring some of these assays to some of the best automated platforms that are available right now. So with that, I'd like to end my presentation. Of course, thank all the collaborators, in particularly UPenn and BMS, for assisting in getting the heart failure consortium samples. Without that collaboration, which is a great example of academia and pharmaceutical companies working together, I'm not sure we would have found such strong evidence for a prognostic association between risk of outcome in HFpEF patients. Thank you.
Great. Thank you so much, Alexander. So now the Q&A session will start. So I would encourage the audience to ask questions in the private chat and address them, and then I will relay them back to Morten and Alexander. So I've already received a couple of questions. So first one is from Padu from Indiana University. And his question is, why is endotrophin specific to collagen type 6 and not specific to other collagens like collagen 1 or collagen 4?
I can start, and then Alexander can follow on. I think it's a good question, because we are used to dividing collagens into families, networking families, or fibrillar collagens or facet collagens. But in fact, type 6 collagen, as I showed in the developmental tree, is a little its own character. It is, and in particular, the A3 chain of type 6 collagen is very, very different from all others. So there may be a few similarities to type 6 collagen out there, and we can debate that another day on how to use those. But type 6 collagen A3 is truly different from all the others in terms of development. The fact that it has 10 von Willebrand binding domains, that it can be a so intrinsic part of wound healing and driving fibrosis. We do not see that from other collagens. Do you want to add anything to that?
I think you covered it pretty good, yeah.
Thank you. All right, and another question. So do you see similar outcomes in patients after kidney transplant that will develop chronic allograft nephropathy from interstitial fibrosis and tubular atrophy?
So I can start, and I wish we had Federica Genovese on the call. She's really our kidney expert. But for some reason, and we've had a consortium called Eurostar with Federica's group doing kidney work. PRO-C6 is surprisingly good in predicting the death of kidneys, even before renal transplant. So it is actually associated with outcomes, not just in diabetes and chronic kidney disease, but also with kidney death in renal transplant. I'm sure we can have a long discussion on this with Federica at some point. I was trying to I don't know if Jeff, if you were listening or still listening. I thank you for your comments earlier. I think we need to do a kidney extracellular matrix pharmacology session, and I would love if Jeff could lead the way initially, and then we can have other discussions on kidney here, because I think it's an important organ. And it's also, I mean, I'm sure that most of you were sitting and thinking, "Oh, fair enough, Pro-C6 goes up in CKD. That's because that the filtration goes down, and therefore it's confounded." No, in fact, we measure similar high levels in urine. So it's not because of loss in kidney function. It's because of a central pathological feature in this. And I think the kidney question warrants a whole session, actually.
Thank you, Morten. All right, then we have Rohan from School of Rock. He asks, you showed that endotrophin can change with treatment in interventional trial. Could you use it as a patient stratification biomarker in IPF or NASH or other fibrotic indications?
Yes, I believe you could. I think we have yet to see a clear-cut case in those indications at least, but I think based on the premises that elevates or that leads to an elevated levels of endotrophin, I would expect to see that idea applied with great success in both liver disease and IPF as well.
Can I add to that? So if we are talking about a metabolic disorder, as I was trying to say initially from the Runtanjal publication, that it's an organ death race. And when we include patients, I think we need to accept that it's an organ death race between the liver, the kidney, and the heart. And we need to optimally know those patients being treated for one of those organs, that one of the organs are not beating us to death. So I think we need to do some tissue profiling and look at the organ trajectory. So what is the organ death trajectory? So for that part of patient profiling in those diseases, I think it would be an optimal way of doing it. It could be used, so there will be a profiling of that. And of course, as Alexander showed, FDA supports the use of Pro-C6 as a patient enrichment tool for cardiovascular diseases in HFpEF. So, and we're very interested in the organ death trajectory, because it also talks about what is the patient endotype that we are including. That it's not just high turnover of all the three organs, but there are differences between those organs. And of course, treatments will have a basket of benefits on those different treatments that I think we can get a handle on by doing a few different biomarkers. Good question.
Great, thank you. Then Matthias Locker from Tribune Therapeutics asks, do you have mouse models showing similar effects like patients? So essentially, are biomarkers translational?
Yeah, we have a rodent assay for Pro-C6 as well. In terms of showing the same trajectory as patients, I guess the ZDF data that I showed is probably the best piece of evidence we have right now. I mean, rodent models, particularly mouse models, are notoriously difficult to get to mimic the exact clinical pathogenesis. But yeah, I think we have some models, particularly in the rat and in the diabetic and obese models, that mimic quite nicely what we see in a clinical picture as well.
Great, thank you. And then Divya asks, I'm curious to know whether endotrophin can be used as a biomarker in various anti-fibrotic therapies in treating different metabolic diseases.
That's an interesting question. I think that really hits the head on the nail, because I mean, now we're sort of tapping into the whole discussion whether or not endotrophin is actually a causal biomarker. And I think the hypothesis is definitely there. It supports that it is a causal relationship between outcome, especially when you think about the experiments we've done in vitro and also the work done by Dr. Sierra, highlighting that for one, it is directly profibrotic, and it's also associated to this sort of systemic inflammatory component. So whether or not it is true antifibrotic strategy to target that molecule, I think we'll have to investigate, but I think the hypothesis is definitely there.
I interpret the question a little different, and so I can ask in a different manner. If you look at the Award 7 study, then we know that anti-diabetic treatments, they are also investigated for their MACE outcomes, right? So in their cardiovascular outcomes. And we did see that there was a decrease. We know there is a decrease in cardiovascular outcomes with a GLP-1 molecule, and there's also a decrease in PRO-C6 with a GLP-1 intervention. So if you lower the metabolic sclerosis, the metabolic drive, then fibroblasts gets less activated. So I think the question is, at what time can you actually see that a decrease in PRO-C6 as a pharmacodynamic marker translates into clinical efficacy at a later time point, just as CTX1? So what we think right now is as there is an association between the effect on compounds in the metabolic space that have an effect on MACE and on outcome for cardiovascular outcome, that we eventually will be able to make that leap. We call that a dual action. If you had an effect, if you have a compound that's both affecting fibrogenesis or fibroblast PRO-C3, and in addition in the NASH field, those that will have a cardiovascular benefit on PRO-C6, I think those compounds will have a added benefit as compared to single modulators. Interesting how you can interpret the same question in so different ways.
Indeed. Then we have an anonymous question. Can the PRO-C6 biomarker be used as a surrogate endpoint in clinical trials?
To elevate any biomarker to the level of a surrogate endpoint, then we need an interaction process with the FDA, and for that there is still some time. I think right now we can use it for decision making. We can use it for dose finding. We can use it to have quantifiable, objective decision points earlier in clinical studies. Eventually, will it become the HbA1c of heart failure? Well, we hope that, but then I think we need to talk again at least next year or next year again. But that is the direction. I think it's also important that we're moving it away from a research question. It's not does this biomarker go up and down? We're looking into threshold clinical values. That's the whole idea by the interaction with FDA to make something that can be used for clinical decision making and for the benefit of patients.
Thank you. Then Sandrina asks, so to your opinion, is this increase in endotrophin release a consequence of the disease or a cause of the disease?
Can we take the Fifth Amendment on that? I think we are super interested in endotrophin, and I think it's we need to further investigate what is the interaction between the A3 chain is endotrophin and the relation to platelets in driving a disease. I think the jury is out there. I think if the question was asked to Dr. Scherer, who I think is maybe on the call, then I think he would be saying, yes, there is a causal consequence, and we're investigating that. I think it's very important which context that is in. As I said initially, then the context, the extracellular matrix, often confers the signals to cells. So I think there's some debate on that. That was yeah.
Great, thank you. So then Dirk from Icahn School of Medicine at Mount Sinai asks, fibrosis is often part of normal regeneration, which also involves resolution. So what mechanisms do you think changes physiological transient fibrosis from pathological persistent fibrosis?
Oh, can we? I would love an email to have additional discussions on that. So I view this as the difference between an acute matrix and a chronic matrix. In the minute that you have an injury, in order not to die, you need wound healing and clotting. So you need an acute matrix, and you need an acute matrix that is part of a wound healing cascade, really dragging in platelets. And then a chronic matrix is what is left when you have had that. Interestingly, when we activate fibroblasts, we see that activated fibroblasts, they produce PRO-C3. It's rather easy to have them produce type 3 collagen and type 1 collagen. You need truly activated fibroblasts. They need to be really kicked before they start producing excessive amounts of PRO-C6. So it's not just active fibroblasts. It's really hyperactivated fibroblasts that are primed for making an acute matrix and that are enabling a wound healing response. I think there's a biology part in this that is super interesting to explore, and shoot us an email. I would love to discuss that.
But I think also just to add on that, we've actually shown in the in vitro experiments that when we treat the fibroblasts with TGF-beta, that does not stimulate type 6 collagen formation, at least not in kidney and heart fibroblasts. But when you treat them with PDGF, or coming back to Morten's hypothesis about wound healing and the involvement there, that actually significantly induces type 6 collagen formation. So in addition to an acute versus chronic matrix, there's also a differential stimulation by growth molecules or profibrotic molecules that are interesting in relation to the biological context.
Great. And then one last question. So there are a lot of groups looking at proteomics and who suggest that we need to look at panels of hundreds of proteins. How do you think that we may best possibly make a difference for patients? Is that using proteomics? Is that using Nordic biomarkers, or is it a combination of it?
I think it's a good question. I think first of all, to move clinical chemistry further, I think we need to accept that when we find a new protein on an array, we actually need to find the epitope that carries the most value. One of my good friends, Virginia Krause, just did it in OA. She looked at vitamin D receptors. If she looked at 3 of those different fragments by proteomics, 3 of them were prognostic for progression if they were high, and 2 of them were prognostic if they were low. So the same protein, different fragments, completely different prognostic value. We need to find the right fragment. And I think we need to move from discovery onto platforms. And of course, it's ignorant to say that modern clinical chemistry and making a decision for patients is only one single biomarker. Of course, it's not. But we do need to talk to FDA and validate each single biomarker individually. We need to put them on a platform that is patient adjacent, that can be used in different places of the world, and where we can relate a change in a number to that patient. Think of HbA1c. When it's one of the best biomarkers in the world, and we all know if we are on this level, then we are pre-diabetic. If this is highly diabetic, and the patients can understand changes. So by the end of the day, it needs to be patient-centric. It needs to be understandable for that. Panels, yes, but I think we need to refine them, and we need to select the most important ones, and we need then to make numbers that the doctor can relate to, and that the patients want to change, and then can see are changing through interventions. Good question.
All right, thank you so much. So we've come to the end of the webinar. I would like to thank the audience a lot for participating this event. Please keep an eye on your emails, because we will for sure organize other topics as well. For example, on neutrophil activity, on fibroblast activity, and other well-known and hot topics in the extracellular matrix field. Please have a look at the evaluation page after this webinar, and feel free to reach out to us if you have any more questions. You will see a page right after this where you will see the email address, but otherwise here it is, mba@nordicbio.com, and then we will make sure to redirect the questions. Thank you so much. Apologies for the small technical problems at the start, but we were very glad to have you here. Thank you.
Thank you, everybody.
Thank you.
All right. If you press the exit button on the top. Thank you.